We were called to a Code 1 75-year-old male who was unconscious. On arrival, patient was lying on his bathroom floor, GCS 3. After taking a set of vitals, the patient was setting low at just under 50%. I was responsible for bagging the patient using a BVM at 15 litres a minute, while my mentors gathered a history from the family, cannulated, etc. The patient had a history of emphysema, which my mentor decided to treat the patient for. After a while, the patient's SATs improved to mid-90s and GCS to a 14, as the patient was slightly confused. The patient had a wheeze, so treated with 5 mg of salbutamol, 500 micrograms of Atrovent via a neb. The patient significantly improved in our care. When I arrived on scene, I was not exactly sure what to expect. The call came through as only unconscious and there was no other information. Throughout this case, the only skills I was able to do was give salbutamol and bag the patient. This is my first real patient that I had to bag, and I personally think I did an adequate job as the patient's oxygen saturations did improve significantly. Over the past 6 weeks on placement, I had never been to a patient who was a GCS 3 until now. I had also not been to a job where a patient had improved so much in our care. However, I still believe that I don't have the skills and knowledge to deal with this case as patient care in the future. For example, when I noticed how low his oxygen saturations were, the first thing I thought of was to bag the patient using a BVM at 15 litres a minute. Once I started doing this, I was concentrating too much on when to ventilate that I was not even thinking about what was wrong with the patient. This patient was presenting with classic clinical features of emphysema. According to the QAS Clinical Practice Manual 2015, the clinical presentation of emphysema include thin appearance, a barrel chest, dyspnea, tachypnea, pursed lip breathing, intercostal recession, and tripod posture. This patient presented thin, barrel chest, and tachypneic at 32 a minute. According to the QAS CPM 2015, this patient was also in severe respiratory distress. His conscious state was altered, his general appearance was distressed, he could not talk, his respiratory rate was over 18, he had a prolonged expiratory phase, he was using accessory muscles to help him breathe, his skin was pale and slightly cyanosed, tachycardic, and presented with a wheeze. My mentor, who was patient care for this case, was concerned about the difficulty performing CPR on the patient if he was to arrest. This patient was extremely thin and had a barrel chest. According to Agarwal and Lacour, chest compressions during cardiopulmonary resuscitation can be traumatic to patients and result in rib-sternum fractures. The authors state that sternal fractures occur in 1 out of 5 resuscitation attempts, and this would have been detrimental to our patient's condition. If I come across a case like this in the future, I will assure that I perform all the vitals as soon as possible. This will allow me to have my hands free to help quicker. I would also ensure I had all the relevant history of the patient as fast as possible to ensure that I can pinpoint the problem and treat as fast as possible, especially in this particular case which was extremely life-threatening. For example, knowing that this patient had emphysema was vital to this case, which led my mentors to auscultate his chest, which then led to the treatment with salbutamol and Atrovent. If I apply these changes in the future, I think this will definitely benefit the patient. All in all, it was a very overwhelming case. However, I believe I have learnt a lot from this call, which I'm sure will help in the future.